Rheumatic fever is an inflammatory disease that can affect heart, joints, skin, and brain. It's an acute inflammatory disease that affect all the layers of the heart, especially the endocardium, myocardium, pericardium. The main etiology of the disease is sore throat, scarlet fever. Rheumatic fever affects mainly 6 to 15 years of age and common in undeveloped countries. The main risk factor is streptococcal infection, mainly upper respiratory tract infection, sore throat, then familial tendency, previous attack of disease like scarlet fever. Then if we are not continuing the antibiotic treatment, if we missed out the antibiotics, then poor hygienic practices and poor environmental condition and overcrowding, all these may cause rheumatic fever. Pathophysiology of rheumatic fever. Due to etiology, there will be presence of group A streptococcus that leads to immune response resulting in formation of antibodies against group A streptococcus. The antibodies formed exhibit cross reactivity with the host tissues. That's why there will be autoimmune response. So that the joints and the heart also will be affected here. The antibodies acts on the normal tissue and that cause damage to the normal tissue. So there will be the skin, the joints, then the brain also can be affected due to this autoimmune response. So this is the pathophysiology. Due to this damage, there will be signs and symptoms like carditis, arthritis, etc. The main clinical manifestations of rheumatic fever, it includes major criteria and minor criteria. Major criteria, it includes carditis. Carditis is the most important manifestation of rheumatic fever and it results in heart murmur, cardiac enlargement and pericarditis. Next one, arthritis, monoarthritis or polyarthritis. The inflammatory process affects the synovial membrane of the joints, causes swelling, heat, redness, tenderness and limitation of movement. The larger joints are affected like knees, ankles, elbows, wrists are affected more. Next one, subcutaneous nodules. Subcutaneous nodules usually associated with severe carditis are firm, small, hard, painless swelling located over the extensor surface of joints, particularly the knees, wrist and elbows are affected. Next one, erythema marginatum. The bright pink non-arthritic map-like macular lesions occur mainly on the trunk and proximal extremities and may be exacerbated by heat. Next one, Sydenham's chorea. It is characterized by involuntary movement, especially the face, limbs, muscle weakness and disturbance of speech and gait. So that is major criteria, cases. Next one, minor criteria. In minor criteria, there will be fever, then the raised ESR and CRPC reactive protein, the arthralgia will be present, then prolonged PR interval in ECG, then previous rheumatic fever. So that is the minor criteria. The diagnosis of the condition based on major and minor criteria. If there is two or more major criteria or one major with two or more minor criteria, then we are diagnosing the condition as a rheumatic fever. Along with that, we are doing the chest x-ray, then cardiomegaly assessment, pulmonary congestion can be identified by chest x-ray, then anti-streptolysin O can be identified, then increased WBC, all these things also consider. Treatment of rheumatic fever. Step 1, primary prevention. Here we are giving importance to the eradication of streptococci. Second line of treatment is anti-inflammatory treatment. Here we are giving aspirin and steroids. Aspirin 60 mg per kg per day in children, 120 mg per kg in adults. Steroids, mainly prednisolone we are giving, that is 1 to 2 mg per kg per day. Then supportive management and management of complications, that is done by antibiotics, mainly penicillin group of drugs. Next one, secondary prevention, that is giving importance to the prevention of recurrent attacks. The main complications that can be seen here is rheumatic heart disease and heart failure.